Good morning. I call this meeting to order. Will the clerk please do the roll call?
Dr. Lauren Bean. Heather Brissett.
Here.
County Councilwoman Yvonne Conwell. Emily Campbell.
Present.
Dr. Melanie Golembuski. Not present. Councilwoman Tennille Kaus.
Here.
Jasmine Long.
Present.
David Merriman.
Present.
Dr. Connie Moreland. Councilwoman Nikisha Nickerson. County Executive Chris Ronayne.
Here.
Councilwoman Jasmine Santana. And Mayor Kim Thomas. Thank you.
Thank you. So before we proceed, I would like to take a moment and present a statement, and then I will call for a moment of silence and reflection in recognition of the contributions and challenges faced by women across the world. As we reflect on the results of the election nationally and in the state of Ohio, many of us have questions about the impact of our work on the Women's Health Commission. Our work as a commission remains critical, and our dedication to girls, women, and individuals identifying as women in Cuyahoga County remains steadfast. The data that we will hear today is a reminder of the work still left to do to create an inclusive county where all people, especially girls, women, and individuals identifying as women, are valued and treated with dignity and respect. Today, the data will show us barriers faced by girls, women, and individuals identifying as women right here in our home, Cuyahoga County. The narratives will bring real-life stories and faces to the numbers. As a woman on this commission, I am disappointed in the data and the narratives, but I am not discouraged or tired of exploring solutions and implementing change to serve girls, women, and individuals identifying as women in Cuyahoga County. I have learned that each journey has setbacks, but I have also learned through hope, a shared vision, and partnerships without ego, each journey has immeasurable victories. It is up to each generation. It is up to us to continue to do the work that we have already begun individually through our organizations and through this commission to support the needs of girls, women, and individuals identifying as women. Thank you to those who have dreamed before us, the workers at Cuyahoga County who are charged with doing the work daily and do it so well, and to you, my fellow commission members, for your passion, commitment, and energy to the common vision. Thank you. The next item on our agenda is the approval of the prior meeting minutes. These minutes were circulated to the commission prior to this morning meeting. I now invite members to express their opinions or make motions related to this topic. Do we have a motion to vote to approve the minutes?
So. Second.
We have a motion by Heather Brissett, and we have a second by Ms. Jasmine Long. We will now vote on the motion to approve the minutes. All in favor, say aye. Aye. All opposed, say nay. Let the record show the motion has passed. Clerk, has anyone submitted public comment for this meeting this morning?
No public comment was received.
Thank you. The meeting is now open for new business. We will now hear a presentation on the Cuyahoga County Women's Health Assessment from the Center for Community Solutions. This report was put together by the Center for Community Solutions in partnership with Enlighten Solutions. They also pulled data from the health of cis and transgender women from the recent Cuyahoga County LGBTQ+ assessment. We are excited to have representatives from the Center for Community Solution as well as Enlightened Solutions here with us today for the presentation. Thank you.
Thank you, and good morning to the Commission and to the Chair. I'm Emily Campbell, the President and CEO of the Center for Community Solutions, and we are delighted to be here today to share some information, some of which has never been released publicly before, looking at the health and well-being of women, girls, and people who identify as women, stealing your phrasing, here in Cuyahoga County. As the work of the Commission ramps up, we felt that it was important to provide some data and information on the current conditions here in our community, which can serve as a foundation for the work of this body going forward and as a catalyst for conversation. This report was specifically prepared for this commission, and so looks very intentionally at issues that we hope can be that catalyst for conversation going forward. And it provides a comprehensive overview of the state of women's health in Cuyahoga County. We hope to name health disparities, to highlight unique health needs, and to inform community-based solutions to improve overall well-being for women in the county. And before we get into it, I want to make a quick note on language. The understanding about gender is evolving, and we're very rapidly learning more about the spectrum of gender identity. Throughout the report and in this presentation, we use the binary because that's where the data continues to be. And so as we advocate for a more inclusive look at how data is presented about people in our community, we have to go with what we have. So we talk about women and girls. Sometimes we say females. For data on LGBTQ plus populations, we included only cis and transgender women, so those people who identify as women. And we fully recognize that gender is more complex than what's reflected here. But, you know, it's what we have, so it's what we go with. So as was mentioned, this is a partnership between the Center for Community Solutions and a couple of our partners. Let's see. Oh, too far. There we go. Works great. So I'd like to invite my partners from Enlightened Solutions, if I could, up as well, because we are going to be sharing the time that we have here today. Thank you. The Center for Community Solutions and Enlightened Solutions collaborated on this report, and what you hear today shouldn't be considered any type of official position of this commission or of Cuyahoga County. Although I also serve as a member of this commission, for this presentation, we're representing ourselves and our organizations. And as I get started, I just want to acknowledge colleagues from Community Solutions whose work you see reflected in this report. They had other commitments and couldn't be here today, but it would not have been possible without Emily Matillo, Andrew Snyder, Dr. Susanna Teese, and Madison Van Epps. So you see on the screen the Center for Community Solutions and Enlightened Solutions. We also have a third logo, and that's for the Greater Cleveland LGBTQ plus Community Needs Assessment. So in addition to some standard and maybe not so standard data that we pulled together, this analysis incorporates localized and current data on Black women's health and LGBTQ plus women's health to provide a deeper insight into the unique health needs of communities that are often marginalized. Some of this information, again, is presented here publicly for the first time. So to ground ourselves in what we're looking at, there are over 650,000 women and girls who live in Cuyahoga County, who call this county home. There are women and girls in every single community, neighborhood, and on every street across the county. We see them in every corner. And as you well know, there's a great variety in the concentration of where women and girls live in Cuyahoga County. And this map shows the concentration of the female population. Cleveland has by far the largest population overall and the largest population of women and girls within the county. Cleveland has about 30% of all the women and girls who live in Cuyahoga County, and the rest are spread throughout the county, going all the way, followed by Parma, Lakewood, Cleveland Heights, and Strongsville, and then going all the way down to Lindale, which has only 81 women and girls in that small pocket of Cuyahoga County, according to the latest census data. 55% of Cuyahoga County women and girls are non-Hispanic white, 30% are Black or African American alone, 7% are two or more races, 4% are Asian or Asian American, and there are smaller numbers of people who are American Indian and Alaskan Native, Native Hawaiian and other Pacific Islander, and some other race. About 7% of Cuyahoga County's population, or 45,000 women, identify as Hispanic or Latino and can be of any race. So we have a much more racially and ethnically diverse population than the state as a whole here in Cuyahoga County. And here you can see the age distribution, and just a couple of things that I want to point out here. Cuyahoga County and the suburbs have more older adult women age 65 and older than girls under the age of 18, but it's pretty close. About 1 in 5 residents are girls, female residents are girls, and about 1 in 5 are older adults. Cleveland does skew slightly younger, and each age group has distinct health considerations that I hope that you can keep in mind as we go through this presentation. Those under the age of 18 represent the future of women's health, and their priorities often revolve around pediatric care, vaccinations, mental health support, and guidance on nutritional and physical wellness. Investing in preventative health care and education for these young girls is essential in setting them up for healthier lives ahead. Ages 18 to 44 are what we often call reproductive age. Roughly 34% of the female population falls within this group, and they're often balancing career ambitions, family planning, and self-care. Women in this age group benefit from access to reproductive health services, mental health support, prenatal care, and work-life balance resources. And addressing these needs helps foster a foundation of health and well-being during some of the most demanding years of life, and we will see that reflected in the data in a moment. Women ages 45 to 64 are still working age adults, and they're often focused on preventative care, managing stress, and addressing hormonal changes. This group in particular benefits from screenings for cardiovascular and respiratory disease, breast cancer and diabetes, and support for mental wellness and menopause management. Women over age 65 face unique health challenges as they age, and their priorities often include managing chronic conditions, bone density support, mobility, and cognitive health. And with a growing emphasis on healthy aging, resources like accessible healthcare, senior fitness programs, and social support networks are important in helping these women stay active, connected, and engaged. So a draft of the report was shared with commission members ahead of this meeting, and today we are going to go through just a small snippet to tell a story about the health and well-being of women and girls in Cuyahoga County. The report is both concise and hefty. It comes in at about 75 pages, packed with data and information exclusively about the health of women and exclusively about women and girls in Cuyahoga County. We relied on a host of data sources, many of which I'm sure will be familiar. We examined close to a dozen different publicly available sources, always including only the most reliable and only the most recent. We looked at sources from local, state, and federal government, as well as several very well-respected private sources of data. One of our biggest challenges was finding data exclusive to this county, and it was even more difficult to find data broken down by age or by race or by even smaller geographies. There are a couple areas of interest we simply couldn't find timely, reliable data, but what you have is a good amount of information to dig into. We're particularly excited about these two new local sources of data on the experiences of women in our community that focus specifically on women from populations which are often marginalized. Both of these were released just within the past month or so, and our partners from Enlightened Solutions will speak about Project Noir in a moment. But I want to talk a little bit about the LGBTQ+ community needs assessment. This was a community-driven assessment that provides a snapshot of health outcomes and experiences filtered down specifically for cisgender and transgender LGBTQ+ women. LGBTQ+ is an acronym for lesbian, gay, bisexual, transgender, queer or questioning, and other identities, representing a spectrum of sexual orientation and gender identities. Cisgender women are those whose gender identity matches the sex they were assigned at birth. Transgender women refer to individuals whose gender identity differs from the sex they were assigned at birth. And this filtered data brings specific healthcare attention to the barriers and disparities faced by LGBTQ women. We are so fortunate in Cuyahoga County to have these two robust data sources, it would be the envy of counties around the country and around the state, because we have information about the experiences of our neighbors that just aren't available in other places to bring to bear on this conversation. So while the secondary sources tell us a lot about the what, these primary data sources collected directly from residents bring the voice of women and girls in Cuyahoga County more strongly into this room and into the conversation, and helps to give us a window into the why. From there, this group and others in our community can figure out the how. So now let me turn it over to Bethany and Chi-Chi to talk a little bit more about themselves and their work.
Hi, good morning, everyone. My name is Bethany Studenik. I'm the co-founder and managing director of Enlighten Solutions, and we are so happy to be here today discussing some of our work and data here locally.
Good morning. Pronouns she, her. My name is Chi-Chi Nkemra, and I am the Director of Strategy for our organization. To let you know a little bit about Enlighten Solutions is a 501c3 think tank. We are a gender justice and racial justice think tank really centered on the lived experiences of Black women, specifically around the areas of targeted universalism. We research, implement, and publish this kind of research that centers the lived experiences of Black women for the sole purpose of uplifting the entire community. We definitely believe as an organization that not just Northeast Ohio, but our region as a whole can be a leader in racial and gender justice. And we believe that the best way to do that is to listen to the lived experiences of Black women.
So just to talk a little bit about Project Noir, in 2020, Cleveland was ranked the worst place in America for Black women overall. And this piece of research out of the University of Pittsburgh looked at municipalities with more than 100,000 Black women in their population. And they looked at workplaces, healthcare, and education. So those are the three sectors that we look at. Today we're going to be talking about healthcare, obviously, with a high degree of focus. When we looked at that research, Chi-Chi and I wanted to respond because we understood that we were at the bottom of the ranking, but a lot of the conversations we were having in the community was that people didn't understand why, right? What was driving these outcomes? Why is this occurring? And when we have a lot of these conversations, we kind of talk about systems, we talk about outcomes. But what Chi-Chi and I are interested in is what we know is that systems are made up of people making choices every day. Thousands of choices, millions of choices across our county, and those choices add up to inequalities. And so what we look to measure is the tactics, the behaviors, the choices on an individual level that cumulatively create these inequalities.
So in 2020, obviously, we were trying to answer the question, is Cleveland/Northeast Ohio the worst region in America for Black women? We did a completely digital survey that was done during the height of COVID, where we thought we were only going to reach maybe about 50 Black women. We were able to reach over 450 Black women, and in fact, we had to shut the survey down early because the survey started to take root in other places, like Baltimore and Honolulu, Hawaii, we have data from. In 2024, we decided to come back to this research question after COVID, right? After much of the racial reckoning that has been happening across our country, we wanted to ask the question again, is the lived experience getting better or worse for Black women in Cleveland? And what have systems actually done to rectify these issues that 4 years ago were brought to light?
So just to talk a little bit about the methodology, you'll see a couple of different pieces. First is the microaggression scale. And so those are actual statistics. You'll see 70%, you'll see percentages of particular behaviors. Those are questions that we ask the community, how often have you experienced this? And those questions are developed from our conversations with the community. When we're talking with folks, we're asking, what have you been going through? We're listening to these stories. And based on Project Noir 2020, we were able to enhance that microaggression scale based on that feedback. The loop kind of goes into the qualitative feedback. So after asking these microaggression questions, we ask open-ended questions. So tell us about a time you were uncomfortable with your healthcare provider. Tell us about a time that you didn't feel you had adequate access. And then we go through and we hand code every single response. So it takes us time. Chi-Chi and I have read every story multiple times, going through and making sure that we understand what the community is saying. And what we did in 2020 is we did the same thing, and that helped expand and deepen our microaggression scale in 2024. So what you see represented is not only a measurement of what the community is experiencing, but it's also what they've asked us to measure, right? So every time that we do this, we're able to describe the problem with more texture than we have in the past. And so we're really excited about the response rate that we have here in 2024. The energy has not waned. We have more energy than ever around this work, in large part because of the amazing work of my colleague here, Chi-Chi.
So we thought to create a big goal of 1,000. We wanted to reach 1,000 Black women in Cleveland, and we were able to nearly triple our response rate in 2020. That is going against, all of the concerns online, people's lives. Women were gathering together to take the survey together. We had multiple opportunities to co-locate and co-brand with many anchor institutions, many CDCs, many advocacy organizations that were very interested in amplifying our work. In 2020, we only had 4 partners. In 2024, we are over 100 partners deep. Individuals that are very, very interested in not only distributing, but going back to the report, in various different ways, education institutions, healthcare institutions, and workplaces. And we're very, very proud of our response rate. We're proud of hitting 1,300 Black women. And if you look at that map, that's Black women all the way down in Canton, all the way out through Lorraine, all the way up to Ashtabula have been represented.
So when we looked at the data and the data that you see in this particular report, we narrowed it down exclusively to Cuyahoga County because both of these local sources include women outside of Cuyahoga County. For Project Noir, this includes 1,136 survey participants in Cuyahoga County zip codes. And for the LGBTQ plus community needs assessments, it is 545 LGBTQ plus women, the largest number of responses that we've ever had, and the largest number of voices that we can bring into the room with us. You see on the screen a map, and each dot on each of those maps is one survey respondent. On the left, we have Project Noir. On the right, we have the LGBTQ plus assessment. And what I'd like to highlight is that these women are spread across Cuyahoga County. So as you look at this data, please keep in mind that the concentrations may not be where you think they are. These are issues that run across income levels, they run across age, they run across race and ethnicity, and they run across geography. And one final note as we dive into the data, the presentation today will be in a slightly different order than what data is shared in the report so that we can kind of tell a story and weave a narrative about health and well-being for women and girls in Cuyahoga County. So let's start with health conditions and outcomes, which we're looking at the prevalence of outcomes for women's health conditions, and they're influenced by income, age, race, and identity. We want to start with a question that was unique to the LGBTQ plus assessment, and it is looking at different kinds of health, asking LGBTQ plus women, cis and transgender women, to self-report their health on several different factors. On the ends are data we see a lot. Mental health and physical health rated poor, fair, good, excellent, or not sure. But in the middle are other elements of health that we don't often get to consider. And what you'll notice is that cis and transgender LGBTQ plus women in Cuyahoga County were slightly more likely to rate their social health, their behavioral health, and their spiritual health as poor than their physical health. Here we're focusing mostly on physical health, also on mental health, and just a bit on behavioral health. But all of these aspects play a role in what we consider health, and certainly what we consider well-being and quality of life. And so let's start at the end of life, looking at cause of death, and this data is reported from a federal source, looking at the leading causes of death. In some ways, this is the ultimate health outcome. Here we show the 5 most common leading causes of death for Cuyahoga County women and girls, or women, over a 5-year period from 2018 to 2022. Note that COVID is right in the middle of that, and you can see COVID showing up as a top 5 cause of death for women, both working age and older adult. Across all races and ages, diseases of the heart and cancers and tumors are the most common causes of death for women and girls in Cuyahoga County. But when we start to break things down by race and age, we see some concerning findings. The age-adjusted death rate for heart disease and cancer is higher for Black women and girls than other racial groups. Black women in Cuyahoga County were more than 5 times as likely to die from homicide and legal intervention than white women and girls, but about half as likely to die from suicide and self-harm. When we examine the causes of death by age group, younger people are more likely to die from preventable causes such as accidents, which includes drug overdoses, assault, and intentional self-harm. Older women's causes of death tended to be chronic or communicable illnesses. Overall, more than 1/4 of Cuyahoga County females have been diagnosed with either diabetes or borderline diabetes at some point in their lives. And we share this data as an illustration that health conditions in Cuyahoga County show age and income-related patterns. And where we have data for different races and ethnicities, we see differences among those groups as well in these health conditions. Looking specifically at diabetes, because some of these differences are clear, although you'll see it throughout the report. The percentage of women diagnosed with diabetes increases significantly with age, and income disparities are also present, with women below 206% of the federal poverty level having higher rates of diabetes across almost all age groups. For instance, in the 30 to 39-year-old age group, so women in their 30s, 7% of women with lower incomes are diagnosed with diabetes, compared to 6% across all incomes, and this gap continues to widen with age. As I mentioned, we use diabetes here as an example, but we see age and income patterns in the data for most health conditions, including heart disease, hypertension, stroke, and asthma. And I want to highlight asthma for a moment. On page 15 of the report, you'll see a chart which shows the percentage of females in the county ever diagnosed with asthma by income. Across all age groups and income levels, 19%, so about 1 in 5 women, have been diagnosed with asthma at some point in their lives. These rates don't really change by age, indicating that asthma is likely diagnosed early in life for most individuals. But they do vary by income level, with the highest rates among women with incomes that are between 75 and 100% of the federal poverty level, where nearly 1/3 have been diagnosed with asthma. So we're talking about a difference between 1 in 5 to 1/3 when we narrow it down in income. But we started to notice something in the age data which we hadn't noticed before. And you can see it clearly here when we look at rates of obesity by age group for Cuyahoga County women. And it took us by surprise, although perhaps maybe it shouldn't have. Many health conditions seem to get worse with age until we hit older adults, and then the rates begin to fall. So this could be a really bad thing, where it is driven by premature mortality among older adults. So people who have lived with health conditions their whole lives have a shorter life expectancy. Basically, that health conditions begin to catch up with people as they age. And I've noticed myself that people in our community that are of older age, especially those who are in their 90s, seem awfully healthy compared to what we might expect. So we can notice it. The other possibility is that older adults are prioritizing their health more than women of other ages, and so are taking care of themselves, frankly, better, and having their health issues addressed. And that could be a good thing, that we see women being able to address their health considerations. In any case, it's a clear dip in obesity rates for the oldest residents. And as the pie chart shows, the distribution of BMI categories is very evenly distributed in Cuyahoga County. It's not often that we see a pie chart that looks basically like a peace sign, where we have really 3 equal slices that we're taking a look at. But while 1/3 of women in Cuyahoga County have a healthy BMI, just 2% are underweight, and nearly 2/3 are either overweight or obese. Project Noir revealed a particular pattern and experience unique to Black women related to weight. And I want to turn it back over to Bethany and Chi-Chi to talk a little bit more about this.
Thank you for that. So Project Noir, specifically around the healthcare issue, is the fulcrum, right? Healthcare is the fulcrum of the entire report, mostly because the healthcare institutions are institutions for education. They're institutions as workplaces, and they are also places where individuals are obviously seeking care, and usually seeking care at very critical times within their lifetime. So 4 out of 10 Black women have been reported to us that they've been told to lose weight or change their diet or exercise when they went to the doctor for unrelated reasons. In fact, this was so prevalent in our report. We had many vignettes of Black women speaking about this. We had a Black woman go in for a respiratory issue. She had chronic bronchitis, and it was getting worse. The doctor said, you've just got to lose weight, right? She was in crisis at that moment. That's not very helpful, needless to say, when you're attempting to get critical care. And I think what's really key, honing in on this healthcare and weight-related issue, is that it is not just based on income. Many times here in Cleveland, in Northeast Ohio, we say, oh, it's a healthy eating issue, right? It's an issue for neighborhoods that are food scarce or grocery scarce. And I'm here to remind you that it is not. The issue is race and gender and a very specific kind of misogyny that is only happening to Black women. It's unrelated by income levels, but it is something that Black women are reporting very, very frequently when they're trying to seek care at critical times.
So what you see here is some of the statistics I described earlier. And I do encourage you to kind of look at our full report because there's a full body of these statistics and behaviors, but we pulled out 4 for you as an example. 56% of our respondents have been spoken down to about their symptoms or health. Basically, doctors and healthcare professionals not believing what women say, not taking them seriously, assuming that they don't know what the source of their pain is. 55% of our respondents felt uncomfortable with a healthcare provider. And this is a broad data set. People described all kinds of different experiences. There was inappropriate language. There were inappropriate comments. There was, again, looking at the next statistic, this describes some of those interactions as well. 40% of our participants had healthcare staff who had body language, right? This is down to body language, making them uncomfortable. There's things like refusing to shake your hand, refusing to make eye contact. One woman described she came in with a rash and her doctor refused to even look at it or touch her, right? Because they didn't want to do an exam on her. 30% of our Project Noir respondents have also been subjected to painful procedures without enough pain management. And this is kind of the tip of the iceberg when we're talking with the community. Just because you're able to walk in the door and see a doctor does not mean that you're getting the same level of care and access. And these are the gates that women are seeing whenever they're advocating for themselves. You can see here in the middle, I went to the doctor for a painful abscess, but all they wanted to do was talk about my weight. Those stories are never ending. We have so many comments like this. The one that stuck in my head recently was a woman went to the doctor for a broken leg. And he said, if you weren't so large, you wouldn't have fallen and you wouldn't have broken your leg. Right? So again, it's this shaming. It's also an excuse that is used to avoid doing actual diagnostics. And it's also a way of blaming women for the problems that they come in with and avoiding giving the level of care that are given to other populations.
And on that topic of level of care, pain management, and I'm certain Bethany will jump in around the legal ramifications around pain management, but denial of proper pain management is a major issue in Cuyahoga County. Black women of all ages and all income levels are being refused adequate pain management in our healthcare institutions. And again, I have to remind you all that this is not just related to poverty or economics. It coalesces around race and gender. These disparities are the result of scores of individual decisions, from healthcare teams to providers to individuals that are greeting you as you're walking through the door. It's a culmination of these entrenched biases within the system. And specifically around this area of chronic pain management, Black women are severely impacted by chronic pain, right? But they're frequently experiencing doctors, healthcare providers that are not believing their stories or believing that Black women are able to withstand higher instances of pain. Higher instances of pain when you are, again, trying to seek care within a healthcare system.
Yeah, in terms of the legality, I will just say the law doesn't offer much of a remedy here. And I've gotten a lot of calls over the time that we've been working together, and there are things that equate to malpractice, but that's a very high bar. When we think about pain management, this is something that the law hasn't looked at adequately. And so healthcare providers have a lot of leeway in deciding how to properly manage pain for every person that comes through their doors. One woman in particular, her story that stuck with me was that she was a healthcare practitioner. I believe she was a nurse practitioner. And she described that she went in and she had to have, I don't remember what for, but she had to have a shot. And she noticed that her practitioner chose a much larger gauge needle than was appropriate. And when she asked her about it, she said that she believed that Black people had thicker skin. And that was the reason for it, right? So this is something that's still very, very prevalent. In fact, I believe it was 2017, there was a textbook that went viral, a nursing textbook that actually stated these things. This is something that's still being taught as science to our healthcare providers in this region, and it is creating the problems that we're describing today.
And this is a problem that has gotten worse, not better. And part of that has to do with the fact that improper pain management on the other side, overuse of pain management medication, is one piece of the explanation of the increase in opioid addiction in the past few decades, but an issue that most often impacts white men, which is not the group we're talking about here today. But because this is an issue that has gotten a lot of community attention over the last couple of years, we wanted to make sure that we shared data about drug overdoses of females and deaths due to heroin, fentanyl, and analogs in Cuyahoga County for this year. You can see from the pie chart that less than 30% of the residents in Cuyahoga County who died due to heroin, fentanyl, or analogs so far this year are female. Drug overdoses are falling here and across the state from the peak in 2017. Part of this is what we're measuring. So this measures drug overdoses that were treated in an emergency department. So the use of treatments outside of those emergency departments, if they're not transported to the hospital, they fall out of these numbers. But what we're really seeing is the success of community intervention in bringing some of these numbers down. So a story that hopefully we can replicate when we're trying to address other health issues. The other side, this is part of the behavioral health coin, substance use disorder, but the other side is mental health. And this is where we see some very concerning data across the community. This chart is breathtaking. It shows the top health issues reported by LGBTQ plus women in the greater Cleveland Community Needs Assessment, and it exposes a significant concentration of mental health challenges. These figures underscore a heavy mental health burden, with more conditions like PTSD, ADHD, and suicidal ideation highlighting the prevalence of psychological distress among LGBTQ plus women. Self-harming behaviors reported by 12% further indicate unmet mental health needs within this community. And while asthma and COPD are notable non-mental health diagnoses, 8 of the top 10 reported health events involve mental health concerns for LGBTQ plus women, painting a clear picture of the critical need for accessible, affirming mental health support for LGBTQ plus women in particular. And we all know that the current external political climate does not help. This data looks at all women in Cuyahoga County, and those who reported poor or fair mental health by age. You can see that 1 out of every 6 women in Cuyahoga County reports that their mental health is poor or fair, and it's about 1 in 3, so twice as likely for young adults between the ages of 19 and 28 in their 20s. This has been increasing substantially in recent years. Could be for good reasons, that stigma has been lowering, and so people are more willing to report some of their mental health issues. But we also know that it is challenging times, and we are seeing epidemics of mental health concerns, especially among young women and girls. So we are seeing an actual increase in mental and emotional distress, which is not a good thing. Mental health impairment is a more severe indication of mental health issues, defined as having 14 or more days in the past 30 that a mental health condition or emotional problem prevented work or other usual activities. Nearly 15% of women under age 15 report mental health impairment. Let me repeat that. 15% of, or more than 1 in 7 girls and young teens have a mental health condition or emotional problem which prevented them from their usual activities for half of the month. The share of women decreases with the higher age thresholds, but continues to be a concern. One contributing factor to mental distress is loneliness, and frankly, this data really surprised us at Community Solutions. What didn't surprise us is that 1/4 of the women in Cuyahoga County report feeling lonely, and another quarter report feeling moderately lonely. So half of women in Cuyahoga County are experiencing loneliness. But the surprising part is this chart, which shows age, and which is frankly the opposite of what we expected, with women in their 70s and those over age 75 actually being less likely to experience loneliness than their younger peers. And so we kind of wondered what's going on here. We know that loneliness and isolation is recognized as a public health issue because it's linked to serious health conditions. For example, there's a 50% increase in the risk of dementia in individuals who are socially isolated. And social isolation also significantly increases an individual's risk for premature death from all causes. And that risk rivals smoking, obesity, and physical activity. So we suspect that women who remain in the community at older ages prioritize their social connection. And there are many, many efforts, many of which are sponsored by or funded by or organized by Cuyahoga County to connect older adult women to their community in various ways. We focus on older adults' loneliness. We talk about it all the time. And 41% of older adult women in Cuyahoga County live alone, but we're seeing low rates of loneliness compared to other ages. How can this be? Well, there's a difference between being lonely and being alone. And I'll say this is a place where I see myself in the data. Because although working age women are often surrounded by people, that doesn't mean they feel connected. The pressures of work, family, friendships, and relationships mean that I'm constantly bouncing and I'm sometimes just too tired to fully engage in social connections or even leisure activities. And we think this is probably what is happening for women across the community. And I see some nodding heads here. Perhaps with young adults, they haven't really found their people, the place where they fit, and so they're experiencing quite a bit of loneliness as they navigate some big life transitions and how they fit into their own community. We also see stark differences in loneliness by income. Lower income women are more prone to loneliness than their higher income peers. It is stark. 40% of those with incomes at or below 100% of the federal poverty level report feeling lonely, while just 15% of women with incomes at 400% of the federal poverty level or above report being lonely. Let me repeat that. 40% of low-income women compared to 15% of higher income women. 15% isn't great either, but very stark disparities by income. And when we put this data next to another data point, which is alcohol use in the past 30 days by age group, we wonder if we're seeing a connection here. Are women battling their loneliness by using alcohol? There's something here about the experience of working age women which the data is revealing, and we're just not quite sure what it all means. But it isn't something that we often hear talked about, and something which I hope that this commission can think about, making sure that we're addressing the health concerns of women across all age groups and communities. And we're also wondering if this is a pattern that's emerging after COVID, that things have gotten worse, that something has fundamentally changed. We just don't know. But it's a good reminder that no age group is immune to issues related to health. And when we stay looking at the working age women, it brings us right into reproductive health issues. So we want to shift gears a little bit because certain reproductive health issues and the experience of birth is something exclusive to biological females and something which we certainly need to talk about in this commission. Breast cancer is the most common form of cancer among women in Cuyahoga County in the 5-year period from 2016 to 2020, the latest available data. It's also the 4th leading cause of cancer mortality in Cuyahoga County, and the mortality rate for breast cancer is higher here than it is for the state and the nation. Breast cancer is typically treatable when detected early, and mammograms save lives. So do cervical screenings. With regular Pap smears, cervical cancer can be caught early before it reaches late stage and can be largely curable in its early stages. Yet half of women in Cuyahoga County with cervical cancer are first diagnosed with cancer when it is considered to be in the late stage. So they have missed those checkups, or it has been missed. Cuyahoga County's incidence of cervical cancer is actually lower than the state and national rate, but our mortality rate is higher. So fewer women experiencing the condition, but more dying from it. The Ohio Department of Health Breast and Cervical Cancer Project offers no-cost breast and cervical cancer screenings and diagnostic testing for women without health insurance and living at 300% or below the federal poverty level. But in Cuyahoga County, only 5.4% of eligible women received these free services for screening and diagnosis for breast, and only 2.4% received screenings for cervical cancer prevention under these programs. But an estimated 80% of Cuyahoga County's women aged 21 to 65 are up to date on their cervical cancer screenings, and 82% of women aged 50 to 74 have had a mammogram within the past 2 years. These rates are higher than the state and national averages. So we see some differences in the data here, and it's up to us and to providers and community members to figure out what's going on. But the women's health issue that has gotten probably the most attention in recent years is abortion. Birth control and reproductive autonomy is vitally important for the 220,000 Cuyahoga women who are considered to be reproductive age. Cuyahoga County is a place where the full array of reproductive health services has been available to women, and that includes abortion. And women are coming here to receive this service. The U.S. Supreme Court Dobbs versus Jackson Women's Health decision and the varied regulations in states in close proximity to Ohio appear to have affected the number of individuals seeking abortion care in Cuyahoga County. In Ohio, a total of 22,000 induced abortions were completed in 2023, an increase from previous years, and out-of-state residents seeking abortions in Ohio increased by 53%, from about 1,300 in 2022 to 2,700 in 2023. In 2023, 12.6% of abortions occurring in Cuyahoga County were for out-of-state residents, up from 7% in 2022. We don't know what the future holds, but today abortion is legal in Ohio, and it is vitally important that these services continue to be available to women in our communities. And of course, family planning and maternal and infant health are central to the reproductive health conversation. This is actually new data, which didn't make it into the report because we received it this week, updating the data to look at 2023, so we're sharing truly the latest publicly available data. There are substantial, persistent racial disparities in a host of issues, but they are perhaps no more clear than when we look at infant mortality and maternal mortality and morbidity. Overall, for all races of Cuyahoga County women who gave birth between 20 and 2023, more than 76%, initiated prenatal care in the first trimester. We know that early initiation of prenatal care is an important factor which can protect against later maternal and infant health issues. That's a good thing. Black women were slightly more likely to receive no prenatal care or initiate prenatal care in the second trimester when compared to white women, but white women were more likely than Black women to initiate prenatal care in the third trimester. Our infant mortality rates are headed in the wrong direction. In talking to people from First Year Cleveland and from around the community, they suspect that what we are seeing is the result of maternal stress, plain and simple. During the pandemic, there were a lot of resources available to help people meet their basic needs. Just one example is that evictions and utility shutoffs were completely paused, reducing housing instability for people during that time. We saw housing security improve in 2020 and 2021. That's all over now. But let me be clear, this is not a poverty problem. This is about race. A few years ago, a colleague at the Center for Community Solutions analyzed over 88,000 birth records from across Ohio and found that birth outcomes for Black women without college degrees was worse than for white women with only a high school diploma. These disparities exist even when we hold income constant, and there's a growing body of work showing that a good deal of maternal mortality and morbidity and even infant mortality is driven by maternal stress, inadequate support, and weathering, which is directly tied to racism and the experience of Black women. And so no wonder we have such clear data from local women about their experiences coming from Project Noir.
So speaking about these anti-Black stereotypes, the impact of these stereotypes is exacerbating the existing healthcare disparities. And it's making it more challenging for Black women to even receive respectful care. We're not talking about exceptional, we're not talking about above and beyond. We're really speaking about base level of respect. And I want to pause here a little bit for that pause on respect. Second-guessing family planning, second-guessing body autonomy is a recurring theme that Black women are facing within our healthcare systems. In fact, we had an instance of a college-educated, college-age young Black woman detailing that while in college, she wanted to get on a plan of frequent STD testings 3 times a year. So she went to her doctor and stated this. She wanted to be responsible. Her doctor shamed her for that ask. Her doctor shamed her for just implying that she was a sexual being, that she should even take care of her own sexual health. Things that your parents, your educators are telling you to do when you are younger, when you're an individual that is sexually active. That's just one experience. Telling this woman that because of who she is, she should not take care of her own sexual health or her own sexual autonomy.
So this graph looks at something that's come up in both Project Noir surveys. Black women have described feeling pressured to get on birth control or other family planning tools. We talk about it by age here. You can see that it spikes, right? You see 18 to 28, 29 to 39, 40 to 50. Those conversations are happening, and then they fall off as women kind of go past childbearing years, which makes sense, right? There are very few data points in this work that have surprised me, right? We've heard a lot, we've seen a lot. This was a bit surprising to me because anecdotally, right, we haven't done Project Noir with other populations, but when I talk to other women who look like me, we have the inverse experience, which is being told you should have a child now, right? Starting in your early 20s, being pressured to have a child. Most of the women that I talk to that look like me, and there is data to back this up, shows that we're getting different messages depending on our race. Something to note here as well is that Black women have the highest rate of hysterectomy of any population in America. When you talk to healthcare providers, they will say that there are certain diseases and things like that that are leading to this. But when you talk to the community, there are many cases of women being told, there's nothing we can do, we'll just do a hysterectomy. We think that's the only thing we can do for you. And then getting a second or third opinion and getting treatment and actually being able to go on and have children. Right? We talked to some women who, unfortunately, didn't have full informed consent. They thought they were going under for one procedure and came out with a hysterectomy. Right? So I want to be very clear that this is a huge, huge problem that has been deeply described by the community here locally, and it is very, very concerning when Chi-Chi and I look at this, and there are many stories about it.
One of the vignettes that was particularly challenging for me as a young Black woman was this one. A nurse at the hospital made me feel incredibly uncomfortable during a pelvic ultrasound. Her bedside manner was awful, and she treated me like I was just a practice dummy rather than a human being. Again, going back to this idea of respectful care, this is a refrain that was so prevalent in Project Noir 2024 that bedside manner and outright callousness was a major theme here within our healthcare section. So we have some serious challenges seeking care for Black women. Actually, this might be yours.
I think we got it.
All right, cool.
Yeah. I have notes on this.
We've been
about-
so well integrated, so smooth.
So again, this is referring to a statistic we showed earlier. 60% of Black women across Cuyahoga County have reported that they felt uncomfortable with a healthcare provider. I provided some context to provide you another vignette. These are inappropriate comments, right? So one woman described she had just had her child. She's there signing the birth certificate with her husband. And a nurse walks up to the husband, pulls him aside, and says, you know, if you sign the birth certificate, they're going to think you're the father and you're going to be responsible for this child. This is a married couple, right? Experiencing one of the most important things you can experience in life, and there's a nurse pulling him aside, making incredibly, incredibly offensive assumptions, right? So these are things, again, this is a broad definition, but the stories that we saw under this come back to a lot of what we've talked about before, the inappropriate comments, refusing to shake hands, not even looking you in the eye, walking you out the door, refusing to provide diagnostic support. The list goes on and on.
So some of our main healthcare themes, like I stated before, bedside manner and overt callousness. Black women are experiencing extremely dehumanizing and dismissive attitudes from medical professionals, but all the way to the individuals that are welcoming you to these healthcare institutions, individuals that are in security, individuals that are at welcoming desks, right, are dehumanizing and dismissing the pain of Black women even from the first moment that they're placing their feet within the healthcare institutions. It's leading to an incredible amount of emotional distress. An incredible amount of emotional distress, and the opposite, right? A reluctance to even seek necessary care. And it worsens healthcare outcomes when you dehumanize somebody and then they feel as though they don't even want to seek care anymore because of the emotional toll that has gone on within the healthcare system.
This delves a little bit deeper. Again, this is something the community, not only did we ask in statistics and measure it because this came up in 2020, this is also coming up in the major themes. When we're asking folks, what have you gone through? Tell us a story about your experiences. This is something that was a major theme that women wanted to talk about. There are biases around reproductive choices. There are inappropriate comments. There is sexualization. Imagine getting a physical exam and having your doctor commenting on the tone of your body. Right? Those are the types of things that women are experiencing. And again, we want to push back on the framing because sometimes people look at statistics and they say, Black women maybe aren't engaging with their general practitioners as often, or they're doing so later in their pregnancy. Well, if this is how you're treated when you come into the doctor's office, I wouldn't want to come either. Right? I would be putting it off, especially because it doesn't feel like you're getting any type of care at the end of it. You take off work, you pay the copay, you arrange for childcare, you drive over, you talk to the doctor, and you're told, don't worry about it, and you're sent home. Right? Again, this is leading to women, checking out of the system, not wanting to make time to have these conversations because they're not helpful.
So we started off this section around anti-Black stereotypes, and I just want to reiterate, it's creating an extremely hostile environment for Black women, Black girls, Black children even, to seek care within their healthcare institutions, and specifically around the dignity of that kind of care contributes to a lot of mental health issues, individuals not feeling confident that they can even speak freely or openly with their healthcare providers at all. So within Northeast Ohio, right, we live in the nexus of these big, beautiful, global powerhouses, these global healthcare powerhouses that have global esteem, but within living here in Cuyahoga County, there are persistent disparities. Despite this reputation for really high quality care for world leaders, Black women and our families are continuing to face adverse and outright harmful experiences. And we keep saying this because folks keep ignoring us when we say it. It is not related to poverty. Black women of all means, all class, all education in Cuyahoga County are experiencing some of the worst healthcare outcomes when being treated in traditional healthcare systems, which is truly a shame when, global leaders are able to gain really high quality healthcare, but the Black women and families that live within the footprint of these healthcare systems are being dismissed, outright disrespected, and ultimately, some of them are losing their lives.
This is also something that we see very prominently in the LGBTQ plus community as well. 65% of LGBTQ plus women in Cuyahoga County feel that being LGBTQ plus changes how medical providers treat them. And nearly 1 in 4 LGBTQ plus women in our community delayed or avoided healthcare due to discomfort related to their identity, saying that they delayed seeking medical care because of their identity. They think being LGBTQ changes how medical professionals interact with me. I have to educate medical providers about my healthcare needs, and I have to educate mental health providers about my healthcare needs. Overall, 27% of all women in Cuyahoga County avoided or delayed accessing care in the past 12 months. When we look at all women, the entire population, cost was the most common reason for avoiding care, followed by provider availability, transportation, and a lack of provider. But what we're hearing from women from these marginalized communities is dramatically different than what we are hearing from white women in Cuyahoga County. This data comes from a different source, looking at the usual source of care for adult females, and you can see that most of the care is happening at the doctor's office or health center. But 12.8%, about 1 in 8 women in Cuyahoga County, say they don't have a usual source of care. And this, despite the fact, as we'll see on the next slide, that nearly all Cuyahoga County residents are covered by health insurance. You see here health insurance coverage by age and geography. They don't add up to 100 because you can have more than one type of coverage at a time. I want to point out patterns in public coverage, particularly Medicaid and Medicare. It's important to note that 45% of girls rely on Medicaid coverage in Cuyahoga County, which includes 75% of girls ages 18 and younger in Cleveland. And then look at Medicare for older adults. Over 96%, regardless of income, are relying on Medicare for their health coverage. Also note that nowadays being uninsured is an issue almost exclusively to working age women. Uninsured rates in the county for women ages 19 to 64 is about double that of girls and 15 times the uninsured rate for older adults. But health coverage is an issue that we've largely solved thanks to Medicaid expansion here in Ohio, at least under current policy, but something that Community Solutions is watching closely going forward. Access is a completely different issue, and quality of care and the care experience is clearly a concern. So we have thrown a ton of information at you. Thanks so much for your patience and attention. And here's a fundamental question, which is posed by Project Noir.
How are leaders here within this room, here within the footprint of Cuyahoga County, in healthcare research, in education, in recruitment, educational institutions, actively and transparently investing in a comprehensive strategy, not ad hoc, not in small departments, not only housed in your DEI? What is a comprehensive strategy around detailing and eradicating these healthcare disparities for the individuals who are the future generations of our county and the individuals that are birthing the next generation of Cuyahoga County residents? That's our main call to action here. That's our main call to action within this report.
So to the chair and to the commission members, thank you so much for your attention this morning, and we're happy to answer questions or engage in discussion.
Thank you so much to our partners. Opening it up to the commission, it was a lot of information, but opening it up for comments and discussion. Thank you. Just a reminder to use our mics to make sure those at home can hear us. Thank you.
It do work, okay. Good morning. So I was just listening. Sure we all have experienced something that got me thinking about my own health care and recent doctor visits. So I'm always a solution person or preventative, really into prevention. So when we talked about one of the preventable tools, I was thinking what we could do now as a commission is formulate some kind of education changes with residents and doctors about the harm of their words and initial assessments of women patients. Immediate solutions to that and how we can kind of shame them back is each woman patient call out the healthcare professional when the incident occurs. How can we market that to women to know? Is probably developing maybe a bullet point card of some of the identifiers that came out of your report, how women are treated in health-related clinics and hospitals. And a solution C, and I think the county could possibly help with developing that or putting out or paying for that bullet card. And then solution C, possibly some county commercials of the county exec. You know, we gotta first educate our women that they're being treated, or, open their eyes that this is not normal of how you're being treated. And so those were some just quick solutions and listening of what I thought we could do.
Thank you so much for that. Those are things that we have talked about and would love to discuss. I'll be very frank, we have many ideas for solutions, and we have talked with local institutions. Some have been willing to talk to us, some have not been willing to talk to us. Some of the conversations have gone further, some of the conversations have not gone very far at all. Some of the conversations have been take an Instagram photo, post it to Instagram, and that's the end of the conversation. When we get to some of the harder solutions, that's where we really do need partners who can help us kind of convince some of these systems to do things that are new, right? Trying new things. We really want to think about innovation when we talk about this because it hasn't been solved anywhere. We may be at the bottom, but nobody is doing this perfectly by any means. A couple pieces on what you said. In terms of education, absolutely. We need to be thinking about educating doctors and challenging some of the narratives that we're seeing. We've also talked about things like tying these things to performance reviews, tying some of these metrics to those components, because again, training is one thing, accountability is another. In terms of navigation, we have talked about and would love to partner on education for the community, best practices. There are things that women talk about that can help, right, in terms of coming in and talking to a healthcare professional. A lot of women delineated dressing up whenever they went to a healthcare provider. But we also want to hold space for the fact that when you're sick, that's not always feasible. Or when you're dealing with an emergency, that's not always feasible. The other thing I'll just point out too is that this puts a lot of onus on women to be responsible for holding systems accountable. And so one thing we do talk about is when someone makes a comment like this to you, if you've had that experience, a lot of times what we do is freeze or we blame ourselves. In Project Noir 2020, we asked women, when you experienced something like this, what was your immediate response? 95% told us they blamed themselves, right? So it can take time to process, and then, if you're like me, 2 weeks later, you're like, I know what I should have said, right? And so there's that component too, where we do want to provide education, but we've also thought about things like patient navigators, and having systems be paying and footing the bill for that, to have an advocate in the room, not only for pushing back, but also for documenting whenever unfair things do happen. So those are some thoughts we have on that, and we really appreciate your thoughts because I think all of those are things that we've thought about and would love to talk to you about.
Well, if we don't stick together, I'm a boisterous one, but we all have our moments of, you're doing something else and you're not thinking. So there's an easy way because you feel vulnerable when you go into the hospital. So number one, nobody wants to go unless they're getting a checkup or something's wrong. So I can understand how it's easy to not be in the right frame of mind, no matter, where you sit. But I believe empowering women, and I look at that as a little different, we've got to always, there's a couple steps. We've got to always teach them to advocate for themselves. The patient navigator part is great, but what healthcare system, that's an uphill battle. That's not an immediate, because they're going to be fighting back with the cost. Then we're hospital rich here in this county, and I know that all the healthcare systems sit down and meet, I think, on a quarterly basis. I mean, those are the meetings that you get into. Those are the places that they're all sitting there, and you're gonna, present a presentation that women are sick and tired. We're gonna fight back. And if they start, because there are good health care providers out there, if we're being taped, there's some dynamic ones out there that give us what we need, and we just start going there.
I was going to add that a lot resonated with me in the presentation, and you guys did a marvelous job in your presentation. And I agree with Councilwoman Conwell in that we have to start pushing back. I agree with creating a task force. I like the idea of having navigators likewise, because I think sometimes as patients, it's easier when you have somebody, especially when you're sick and you're not feeling well, to be there to encourage you and motivate you. But I would also like to think that we should start with our providers. They need to hear this report, because if they have a sense of how they're being seen in how they present, I should hope that that would help to change their delivery and how they're providing services.
And one example of a place where having a partner in the health journey really shows some incredible benefit is in the birth experience and the having a doula by your side. And the data, you can't dispute the data of how much better the patient experience, how much better the health outcomes are for birthing people and their babies when they have that partner with them to be able to help through this process and advocate on their behalf.
And I turned my light on. Oh, I'm so
Oh,
sorry.
I was gonna, let me add this also. My girlfriend, I have a girlfriend who's experiencing a lot of health issues. And she often calls me before she goes to the doctor. And I'm telling her, write this down and tell them this and look this up. And if they use a word that you don't understand, ask them to break it down. Use simple term. And she calls me often and we encourage each other. And when she leaves the doctor's appointment, we talk again. What was the follow-up? What happened? And I'll tell her, go to your My Chart, document, tell them to follow up with you. And it's just having that navigator and somebody who can, empower you really makes a world of a difference.
One of the main reasons when hospital systems have brought up to me hiring doulas to be on their staff, I've been wholeheartedly against that, is that you truly do have to be an advocate for the client, and you can't be worried about your paycheck being tied to your advocacy. Some of the things that get said are they're cavalier and they're not intentionally harmful, but just something as simple as calling someone's husband their baby's daddy, and making statements like that in jest that are very offensive to people. And we have to think, I often use the example of how many times have we, like our personal selves, had a burning question that we wanted to ask our doctor, but we were so afraid that we waited until our hand was on the door to ask the most pressing question, and now the appointment is over. So we do have to educate our community. So many people think, my grandmother, great-grandmother, aunts, uncles, we all use Cleveland Clinic, so we're just going to be a Cleveland Clinic family. And maybe they haven't had the best experience, and sorry for using a name, right? But we don't even think that we can shop around if our insurance allows for us to interview our doctors and say, I didn't enjoy this experience, so I'm going to go somewhere else where I might be treated in a way that I deem more respectable. Because I know when you look at some of these things you shared, I shut down. Like if I get upset in a doctor's appointment, that may mean the difference of me not going back to receive a checkup appointment. And I know better. And so I have to consciously tell myself not to do that. So I think that these themes and really having conversations like that. People call me all the time if they're not in my care and they say, well, Jazz and I experienced this. And I'm like, well, you need to get a doula because I'm not your doula. Come on and get services. Because people think like, oh, I don't want to take it away from somebody who needs it. Well, you need it because you're sitting there and you don't understand what was said to you and you felt afraid to ask the question. So really encouraging our community to know that they can ask questions and then to have those trusted people like myself who will go to the head of midwifery or depending on the department that it is and say, this is the experience that we had with nurse XYZ, with Dr. So-and-so, and what are you going to do about it? And actually expect for things to actually be done about that. So I think that's a very poignant thing, and as you guys kept bringing up the part about, we know that this is a race and gender thing. Can you maybe speak to themes that arose around the workplace? Because that's another assumption that I have from doing this work, is that going back to work after being remote for 2 or 3 years may play a role as well.
Well, workplaces is my jam. So specifically, one main theme that we saw in workplaces was this specific phrase, the rise in coded language around DEI candidate or DEI hire, right? So this also, like we stated before, this bleeds into the healthcare section as an individual that is seeking either healthcare or an individual that is, working within a healthcare system. Coded language is a major theme. We see it in healthcare, we see it in workplaces, and we see it in education. And many times, folks are given the benefit of the doubt without actually needing it. Right? So folks will utilize language that is coded. DEI candidate for somebody that you just don't like their race or their gender or their LGBTQ status, right? Coded language around individuals not being a cultural fit for the organization, right? They just might not be a cultural fit. We know what that means. And I think what's key in a report like Project Noir, and more broadly, the State of Women's Health Assessment, is the fact that we're not afraid or ashamed to call things out plainly. I'm not going to go along with the coded language. I'm going to repeat back to you what you have stated in the ways that you might think that I'm going to give you the benefit of the doubt. I won't, right? Coded language is particularly pernicious because it allows people to escape accountability, and accountability is what we actually need here in Cuyahoga County. I frequently state at any speaking engagement that budgets are moral documents. Going to say that again. Budgets are moral documents. Where your morals are is where you are placing the most amount of money. If you are keen on cutting DEI, if you are keen on cutting human resources, people management, that means you do not value that section. That means you do not value those individuals. And it is extremely important in the workplace, especially post-COVID, for us to make unencumbered financial investments in our biggest investment, which is our people. Cleveland is a Black majority city. 48% Black. We need to be investing in the individuals that are birthing the next generation of Clevelanders, birthing the next generation of Cuyahoga County residents. That is our tax base. If I can just remind folks, that is our tax base. So if we are not investing in these individuals, we're doing ourselves a grave disservice.
Hello, Connie Moreland, Metro Health. I'm in medical diversity and inclusion work there, and I'm also an OBGYN. And I just want to thank you for your comprehensive research and your presentation. Excellent. Quite sobering information. Literally, I'm overwhelmed. And I know my colleagues here who are physicians, we are, I'm sure, in deep thought because we can validate what you are reporting. We do see it. And I just want to repeat that we do see it. And so just thinking about many, many years ago, I remember when Barack Obama became the president of the United States, I had my little speech ready just in case he asked me what I thought were what I thought was the number one health-related problem in America. And I decided that there were two. One was that people were alone, and the other one was that nobody cared. And that was based on my observations. So you've come forward today validating what I saw 20 years ago, and I think it's probably worse now. So thinking about solutions, being alone and nobody caring, and these problems here in Cuyahoga County. And one thought I have is that we need to educate women that they are not alone, that these experiences of disrespect, especially for Black women and all women, frankly, but especially Black women, that when you experience it, that it's wrong, and that, of course, you're not alone. And number two, somebody does care. Who cares? Cuyahoga County cares. So what is our process for reporting this across institutions and documenting that it is happening in real time? Just like, human trafficking and other problems that we know, child abuse, assault, police brutality. How do we report this independent of a given hospital setting? So a woman encounters it, and you are in the bed, you're receiving care, you're afraid of the provider, literally, the person who you should be trusting. Is there a hotline that you can pick up the phone? Is there a poster that says, call this number? Are you being disrespected? Are you being denied care? Are you not being listened to? Should be in the emergency room. You can call it the point of care. I think Cuyahoga County can participate in that education process and creating that network of hotline and communication.
I want to follow that. My name's Lauren Bean. I'm a pediatrician, and I see patients in clinic all the time, and I just want to say this is obviously incredible. Thank you, and I feel like I agree that this information, we should be treating this like a crisis. I mean, we are in a crisis. Black women are suffering and are dying, and you have the information that shows that, and we should be requiring that everybody who takes care of patients in the area and beyond has to reckon with that. And so my first thought is, I mean, obviously we need to get this information into the hospitals, and everybody who works there, I really believe, needs to hear this information, and it needs to happen now. And then my second thought is that I love this idea of a hotline. When everybody was talking, I was thinking about how sometimes I have patients who have like an interpreter with them, and so they'll if they're they don't speak English, or their English is not their first language, we always offer a tablet that has the Marty interpreter. And I just was thinking, like, gosh, wouldn't it be wonderful if we could have somebody on a tablet who could be there advocating with you in the room and pointing out, like, this is, this person is not addressing the concern well, or they're not listening, and have that advocate just right there with you. And I mean, we require, we always, so if you can't speak English, you can have access to interpreter. We're supposed to always offer chaperones, and if we're worried about patients being inappropriately treated, and to the degree that they would be able to have a chaperone, I don't understand why you wouldn't be able to have a chaperone because you're worried that you're not going to get the care that you deserve because you're a Black woman. I mean, it's just as bad. So anyway, I would love to help in any way that I can, and thank you very much.
If I could just quickly respond to that. I think that this is one reason doula care for Black women is beneficial, because it's kind of like having that person there advocating for you. And also the language barriers. I've often seen, and I do support having interpreters in the healthcare setting. They're much needed. But Black women speak English, and so who is there? So the doula birthing experience is awesome. It's a bridge. It's an opportunity. We can look at those models. But I think that's why we continue to see the disparities, because Black women don't have, they don't have a language barrier. They don't have this, or they don't have that. And they're kind of stuck and very susceptible to racism. I mean, we don't want to come out and say that, but it's racism, systemic racism that's occurring. And we're seeing the results of that. And there's an expression often we've heard that when America gets a cold, the Black community gets pneumonia. So this is what we're seeing. Women are suffering in our healthcare system, period. But when women suffer, Black women die. So this is what we're seeing.
I wanted to echo what you said. It was really powerful. And when patients are going through something, they want to know how to advocate, who to tell. I've been through that myself. You sitting in the hospital room, something happens, you can't tell the person who just did it, and then they're following up, keep coming in, so who do you tell? So I think that that's something we definitely need to concentrate on. And with that, it's important to educate our patients to advocate for themselves. Who do they tell? How do they tell? What to look out for, what questions to ask, how to have your questions prepared for your doctors when you go into appointments, et cetera. Being taught how to advocate is so important. And with that, then we talk about how Councilwoman Conwell said there's places in hospitals for meetings every quarter where we can maybe have panels of patients who've been taught how to advocate, go in and discuss their issues with the doctors. I've been in those panels before, and it is excellent. I've moderated some of them, and the doctors will come up and say, wow, like I didn't know. I didn't hear this before. I'm so glad that you told this from your perspective to the patients, and it's powerful. So I think that's something we definitely need to have here in Cuyahoga County.
Chris Ronayne, County Exec. I wanted to first echo the sentiment everybody has, I think, said about the great appreciation for Enlightened Solutions and Project Noir. Thank you. I mean, it sets this stage for our work, really. And I think from the conception of this commission, which really, frankly, happened right at the height of the Dobbs decision, but to get to where we are already, I'm proud of what the work that my colleagues are doing and our team presenting to us today. Thank you, all three of you, and your organizations. I wanted to say, I feel, and I'm certainly with Councilwoman Conwell and everybody else who's spoken, that we need action. And it is. I heard you say it, and I'll say it loudly. It is a crisis. What you've presented, and it's clear in front of us. To Dr. Moreland's point, it is systemic racism. We just need to say it, and hope others are saying it too. The report was coming out. I was just writing some words, and just to repeat them to you, what I wrote, I had the words culture, conduct, language, messaging, access, and education. Kind of a mouthful, but I think this is the duality of caregivers and patients. That we have to face it on two fronts, right? And maybe in an Uber way, our entire community. I do want to underscore, as a person who works for you, that Cuyahoga does care. And this administration cares. I know my council colleagues who are here today, Councilwoman Conwell, and Councilwoman Turner, and everybody on this commission, we collectively care. I just want to say that I endeavor in a lot of county initiatives, and I think about the importance of all of them. The two that come to my mind constantly is the Women's Health Commission and child wellness that we've been working on, not to exclude anything else, but these are things that we are, as administration, just been really, really focused on. But today gives us, I think, a crystallization. So a few things I just want to say in the spirit of action, and some of this may already being done. To state the obvious, we want this as a marquee on our website. And if it's already there, good for us. But it needs to be known to the public. And persons who are, invested like we are in the space need to have access to reports to the extent you're okay and willing with that. That's an easy drop in to do. I want to say that I think I'm going to ask a question later, but it has to do really with where have you gotten with hospitals thus far, and can we help? Can we help get there? A couple of different proposals have been made, and I'm not pinning it all on hospitals and community-based caregivers. It's just, can we help get a forum? Certainly would be one to pick up the phone and start talking about the importance of this to employees. And I think we have, as you come to Cuyahoga County as an example, you get an employee manual. You get the employee handbook. I think we need a kind of not to over word it, but we certainly need a code of conduct, in community about, how we're conducting ourselves in our messaging and our language and such. So it's just another thing that comes to my mind is, can we actually institutionalize this within institutions with kind of conduct, ethics and conduct. Another thing that comes to me is I was struck by struck by all of this, but struck by the isolation issue that was referred to, and particularly in women in the middle of ages. That was said to me when I was seeking this office, and it was said by a professional in Metro Health who said isolation is one of our biggest public health problems, and obviously coming out of COVID at that time, sure, it has been exacerbated, but it sounds like it's still an issue not related to COVID that it is with us, the isolation. So I kind of begin to wonder about using some of our community-based partners, whether it's CDCs or others out there, to create more social hubs that have literally to do with health and wellness. Can there be a place where, you're right, it seems like our communities, I know the mayors across this county, focus a lot on senior centers, right? But are there everything from teen to, sort of middle of ages centers that are social hubs where people feel belonging and feel, that they're in a place where people care and there's access to information and advocacy. So I think on the county side, just kind of doubling down with our nonprofit partners on those social hubs. I was writing as my colleagues were talking about a lot of ideas. I'm with you on the hotline. If that's not already out there, and I loved what was said by a couple of you about also it being arm's length from within the institution of a hospital, that, we have a better business bureau. Why wouldn't we have a better health bureau, right? Why wouldn't we have a hotline for health? As staffed by persons who are one arm's length from somebody who might be telling them what the answer is rather than seeking the answer with the patient. So I think the hotline is a terrific idea, and to have navigators and advocates at the other end of that who are unbiased in the sense of an institution that they particularly work for. Maybe that's something we seek grant funding for to actually staff up, because this is a crisis, right? And well, those are some thoughts to begin with. I think the last thing I want to say, and I mean, if there's ever, I know that we all can kind of get a little bit sheepish about the trials and errors of community summits, but if there is something to be had in that regard, I mean, I think certainly would want to help take this information and get it out there. So easy, low-hanging fruit, things like websites, making a call to a institution about, hey, will your whole team hear us and maybe address the conduct and ethics within, but to a community summit so everybody's hearing this. I'm all for all of that. I think with all of this data, which is incredible, it gives us a baseline for the next few years of work here, but the data needs to lead to strategy, needs to lead to action, right? And so if there's an action plan that comes of your work, that's another thing I'd like to work with you colleagues on investing in. I've said a lot. I'm sorry to take so much time, but really inspired.
So thank you so much for everybody's ideas and thoughts around this. I haven't heard anything that Chi-Chi and I haven't kind of thought about, and it's so exciting to be in a room with folks who also see there are solutions to this, right? We didn't even have to name them, and you're coming up with so many of the things that we know we need to do. So that's what the next step is. To the point about loneliness and isolation, one of the major things that we hear from community members is, this was the first time anybody asked me. And we also hear, I thought I was the only one, right? So women, again, when we talk about this, the number one thing is self-blame. I caused it. I said the wrong thing. Maybe I should lose weight. Maybe I should do these other things, right? So part of it really is that awareness raising of, you don't deserve to be treated like this. Other groups are not treated like this. This is not normal, right? And there's so much community to be built around that. So Chi-Chi and I have been working, we're fundraising right now, to build spaces where people can come together and talk about this as a baseline, right? In terms of things like a hotline, translation, we love these ideas. I will say, when we've talked to healthcare institutions in the past, the thing they will say about that is, well, we have an ombudsman. But to Jasmine's point, ombudsmans are embedded in the organization, and when we talk with the community about this, there's no support really from ombudsman's offices. We need something where independent. We need folks who are very, very literate in particularly these intersections. So those are important pieces. To your question about how far have we gotten, there's a reason we've done a second survey, not only to deepen and continue the conversation with the community, but because we've been brushed off in a lot of ways, right? We had a lot of conversations in 2021, 2022, especially with what was going on nationally, but those have dried up. in the past year or two. And so we had conversations, but again, we didn't see the large-scale investment. We didn't see large-scale programs or changes. And so while we asked the question, has anything changed, we went into it knowing that there hasn't been investment and likely nothing has changed, and that is what we found. And so everything that's been suggested, we are interested in pursuing and talking about. And I just want to be very frank, we're at a point where we need help with that leverage. And bringing people to the table to, initiate actual change, right? A lot of what we talk about, people will lament it. They will say it's not right. They'll be frustrated. But when it comes to Chi-Chi's point, budgets as moral documents, we're not seeing the investment that we need to see to make changes.
And I'll leave you on this point. It has to leave the DEI committees. It cannot just be housed in human resources. This has to be for all members of any kind of hospital system. When I say from the parking lot attendant all the way up to the chief resident, all the way up to the individuals that are making hospital administration decisions, it has to leave the silos of the DER departments or the human resources departments, because this is absolutely everybody's responsibility. Now, we are not here to say that everybody has to do everything all at once. Our main mandate is to make sure that the people at their intersections, the job responsibilities that they have, are informed by the lived experiences of Black women. And at their intersections, at their responsibilities, that they are being accountable to the individuals that are their neighbors, their colleagues, their friends, and their clients within these hospital systems.
Good morning. As I thought about what I wanted to say, my mouth got drier and drier because just listening to this can be very traumatic. I was looking for my dot up there in one of those surveys because I did take the survey. Been a proud supporter of your work and want to thank you for continuing on this courageous journey, as well as Emily. I know I've tried personally, as well as through my position here on council, to be supportive of your work financially and otherwise. So I'll be equally committed to the process as we continue to move forward. I did have some things that I jotted down, and I was grateful to hear the executive's commitment. He has been committed. He's followed up on this commitment. And I just want to point out that, we're talking about healthcare largely today, but this is a phenomenon that's happening in every aspect of our society and Black women's lives. And I'm also grateful that you have so much leadership here today. Director Merriman and Laurel Diaz and Sabrina Roberts, and you too, Benji. I see you back there, and I think David Rosum was here, which is a clear indicator that he's willing to put multiple brains and resources to try to solve this problem. And my colleague, Yvonne Conwell, is the chair of the Human Resources. I'm the chair of the Human Resources Appointments and Equity Committee. She's chair of HHS. So I'm looking forward to continuing to talk internally with the county team to figure out how we can be supportive. I'm meeting with CEO Alexander from Metro Health very soon, and this will be another topic that we can talk about with her. It'll be an introductory meeting for us, but I'm very excited to hear about her vision for the hospital, considering the path that we just came from with a Black woman leading that organization. And so, and I personally want to just say to you, County Executive Ronayne, who I count as a friend, right? But this is business. I want us to take a deeper dive in Cuyahoga County about the status and the health of Black women in our organization. Often, 2 times, I hear way too much about those who are being reprimanded and fired. And a lot of times it's Black women. They're also leaving our organization. So I said that as softly as I could, knowing that we want to address the health of all of our employees, and I know that we will have a commitment to do that. And I think that's pretty much all I wanted to say. I want to thank all of you on the commission for your commitment, brainchild of our executive. So again, I just can't commend him enough for having the vision and the leadership to take this beyond just a thought. And I'm committed to helping you do whatever we need to do to move the needle forward.
I'm from Neighborhood Family Practice, a community health center on the near west side of Cleveland, and hopefully a representative of our community health centers, although we're dwindling here in Cleveland. We typically are a place where we hire individuals who understand this or have experienced this or have come from the communities that we serve. And that is really difficult in terms of thinking about recruitment, retention. And so I hope we kind of think about this in educational spaces of all ages, about how do we encourage folks of different diversities and backgrounds, you know, to enter healthcare or to take this message into whatever the field they pursue. The other thing that came into my head is when Dr. Bean talked about this, you know, in the confines of the word crisis and how we responded with the opioid crisis. There was training, there was messaging, there was all of this stuff coming straight out of the state medical board. And why aren't we doing it with this? From the standpoint of community health centers, we have a really strong group from the Ohio Association of Community Health Centers. I'll be leveraging my contacts there to share this information to see where can we get loud about this from the community health center standpoint, really a very important focus of health in communities that we're talking about, but also why aren't hospitals going back into those communities? Why are we, you know, building centers farther and farther out? I think is also an important question to ask. The other piece that I was thinking a little bit about in hearing the conversations is about how do we create a framework for organizations to do this. And there's lots of frameworks that exist, but something very simple. And I think about our experiences at Neighborhood Family Practice and how we're trying to ensure we do some of this work across the whole diversity of patients that we see. You know, how can patients know who is doing this? And 100%, there's not enough people right now. So if we would post names or hospital systems or organizations that have said, I'm taking a stand on this, I'm training from the front to the back, from the bottom to the top of my house, I'm training people on this. You know, how can people know that this is a safe space, you know, where people have at least received some message that this is important, some education that this is important, and take that name and show up for an appointment with that doctor, with that nurse practitioner, with that nurse, with that dietitian. You know, how can we achieve that? Knowing that there is definitely not enough people to go around to start that, but when you talk about the numbers and you talk about the percentages, you know, 48%, the numbers will talk to the people not listening right now. And when they see other systems and other places signing on to be a pillar of this work, you know, unfortunately, that might be something that turns people's heads a little differently. Yeah, thank you.
Can I follow up with a little idea? This sounds dumb, but little things can kind of be helpful sometimes. I was thinking, you know, even just having like some kind of a way to say like, I'm an ally. You know, not that I should have to say that I'm an ally, but like, you know, if I had something that I could wear every day that said like, I provide respectful care, which I love that term, respectful care. Like I stand with Black women, like just something like that just says, or I am a physician against racism, or something that shows that I have examined this information. So like after, you know, say if we had an educational campaign, once you have, you know, heard this, you can have your pin or you're something that hangs on your badge. Like, you know, we have a lot of people that work in the hospitals have things on their badge. Recently at UH, I've seen people have their gender pronouns on their badges now, which is pretty awesome. But like, you know, one of those kinds of hang tags. But then it also just shows, I don't know, I think it just would be a nice statement. And because that should just be, I mean, we shouldn't have to do this. It just should be the way that it is, but it's clearly not. And I think that could be helpful.
Thank you for that. I think a couple things we've thought about are things like a certification program. So having something where, you know, if it's going to be something that we're endorsing, right, we want to make sure that folks are doing the work. in order to have something, like a certification or a badge. But so we thought about things like training. We've also thought about things like metrics. Something that's come up often has been women talking about, I wish I knew which providers had higher infant mortality rates, lower maternal mortality rates. Right now, there's no public disclosure of those statistics. So part of, if we did a certification program, would be that, disclosing those types of things publicly. 100%. Exactly. Women deserve the opportunity to know who they're going to and what their outcomes really are. And so, we want to put some meat behind it because we don't want to have a situation where people are putting the badge but still having the same behaviors, right? So we have to have some sort of accountability around that.
Just adding the perspective, especially as a Black woman in this climate right now. Pins are great. Policy is better, like Bethany stated. It's really, really very important right now, since we are at such a precarious, socioeconomic, political climate right now, to sidestep things that might be seen as, and I'm not saying that that is, but might be seen as more performative than substantive. So I love, my doctor has her trans ally pin. She's got all of the giblets on her Crocs. I think it's adorable, right? She's fantastic. But what I will say is so much more important is that kind of Yelp review, 5-star rating and ranking that is so prevalent in our society. And I know that folks state that, social media and the memification of things is bad, but I genuinely believe that in all services, if we're going to treat hospitals and hospital systems and seeking medical care as a business, then let's be serious like a business as well. So ranking systems are super important, and it is an idea that Bethany and I have been ruminating about for the last 4 years. And we would love any kind of opportunity to kind of push that forward, especially in community health practices, and especially with any kind of leverage you all may have within these healthcare systems, because they are systems.
Thank
guess
you
I would just-
so
I'm sorry,
much.
what
I
are you
am
saying?
so sorry because it sounds like this conversation has been absolutely excellent, and I'm getting the sense from my committee members that we might ask the team to come back at our next meeting, because I feel like there's more that we have to say, and I know all of us also want to take a deeper dive. We appreciate the presentation today, but there is so much more data in the 70-plus page report, and this will give us an opportunity as well to fully engage and look at that too. So please write on your piece of paper, committee members, the comments you have remaining. I want to be mindful of our time. Our next meeting will be held on Thursday, February 20th at 9 a.m. I want to thank everyone for sharing your time with us today. May I please have a motion to adjourn the meeting? Who said that? I'm sorry. Thank you, Councilwoman. Can I have a second?
Second.
Thank you, Ms. Long. All in favor? Aye. All opposed? Let the record show that the motion passed and the meeting was adjourned exactly 1 minute early at 10:59.
With that extra minute, if I may, just
Yes,
beg your
please.
indulgence, can we give our consultant team a round of applause? Awesome. Thank you.
Thank you, everyone. Have a great day.